Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Kevin. How are you doing this morning?
Hey, Dennis. Doing terrific. Thanks for having me on again. I appreciate it.
Perfect. So it's been a hot minute since you've been on. So today's topic is nursing care, and you're probably one of the more advanced high-speed nurses that I know. So I asked you on. Would you mind doing a real quick introduction of yourself?
Yeah, no problem. So currently I'm a nurse anesthetist. I work here in Fort Liberty. My background in nursing, my first job was I was a general care nurse. It was a hospice oncology, general medicine floor. And then I worked in a float pool at a fairly large level 1 trauma center, big teaching hospital. Stayed at that same hospital where I worked as an ICU nurse. Also worked as an ER nurse at that place. Fast forward, joined the military, and I've done ICU nursing, ER nursing. I've done a few other things that the Army has asked me to do in the nursing field, and then eventually I went to nurse anesthesia school. So I was a nurse probably almost 11 or 12 years before I went back to school. Some nurse anesthetists, they'll do 1 or 2 years in an ICU and they move on, but to go to nurse anesthesia school. But I stuck around in non-advanced anesthesia nursing for quite a while. So I've pretty good background in that. But so that's me in a nutshell.
Perfect. Well, you're the right guy for this. So, we have prolonged field care nursing CPG, which I think does a decent job of saying what to do, but what it does not do a good job at all is like, when do you do it? When do you start? Right? And so since you have, I know that you have a lot of experience in this, when am I supposed to start?
Yeah, and this is definitely a conversation I've had with multiple people. Like, kind of, when does prolonged field care start? I've spoken to some providers that think that prolonged field care starts kind of when you make that first dressing change. And I've thought about that, and I mean that kind of makes sense. But I think a better way to visualize it, and this is I had a conversation with Dr. Ahmad Haq not too long ago. And he even helped me visualize it a little bit better. But so you kind of have your point of care injury type interventions. And then let's say you get a patient out of that care under fire, and now you've got them back somewhere, wherever that is. And you're still doing some life-saving interventions. Maybe for me, it would be like surgery, right? Because I'm with a surgeon. And then after you're done with surgery, and now let's just say, like, for visualization, like in a US-based healthcare system, you're now transporting that patient to either the general care floor, or you're transporting that patient to the PACU, or you're transporting them to the ICU. So really, that's kind of when nursing starts. So to help me visualize in the prolonged field care setting, like if you were in 18 Delta or a SACA medic, and let's say you don't have a surgical team with you, but let's use the example of you have a guy with a partial traumatic amputation. You have to complete that amputation. You get them back to wherever they're at. You have a tourniquet in place. And now you're providing some sort of sedation, anesthesia, whatever that looks like. You complete the amputation. You put some dressings on, and then you're done. That's when prolonged field care starts. That's when nursing takes over and starts doing nursing interventions. So I would say in the prolonged field care environment, once you've kind of done your life-saving maneuvers and now you've kind of got to a place where that patient is stable, now nursing takes over. So I jotted down a few things. This is more just housekeeping things of what nurses do. So one of the things we do, and we do it all the time, is we gather data, right? So we assess the patient. We gather vital signs. That assessment is pretty good. I'm in that prolonged field care nursing guide where it's not just vital signs. It's looking at the scan. It's looking at the pulses. It's doing your neuro checks. It's looking at all the interventions that you've done, right? Or a provider has done, whether that's a chest tube or a Foley or an ET tube. or just they put a dressing on somebody. Like you are assessing all of that. And then you have to somehow chart all that stuff, which is time consuming. And really all that stuff is for the providers to come in and they look at that documentation of all those data points and make a decision on what needs to happen next as far as for their medical management. But without that data gathering, like the provider who's ever overseeing the medical management is kind of blind. So that's one of the things we do as nurses, and we do it all the time. And my first job, I was an RN. I was like 22 years old, and I was in charge of 20 patients, and I had some certified nursing assistants that would help me, and I would have some licensed practical nurses that helped me. I still was in charge of making sure I did the assessments on all 20 of those patients. I had to give all the medications to the nurses' aides patients. I had to give IV medications to the LPN's patient. And then I had to sit down and chart on all of them. And granted, I only had to chart every 4 hours because this was a general care floor. We were talking, there's those memes about nurses, not peeing and not eating. And it's true. Like I ran the full time, and it's just time consuming to do all this. And I won't get into like when you have a patient that has a change in their vital signs or has a change in an assessment, then you got to call the provider and you got to let them know what's going on. And that just throws your whole entire shift off because now you're just chronically behind. So one of the things, so we just gather data, and that's time consuming. The other thing I'm just looking at as far as interventions goes, and this is just a laundry list of stuff, like we do pulmonary toileting, we turn the patients, we do skin care, we do bed baths, dressing changes, medication infusions, scheduled medicines, fluids, IOs, chest tubes, like you name it, like the nurses are the ones who are doing this at the bedside. So I think when you're trying to wrap your brain around prolonged field care and trying to wrap your brain around nursing, it's like prolonged field care, the majority of it is nursing, and it's time consuming. And the more patients you have, the less time you have for each patient to do all those interventions. So the other conversations that we've had is just like, well, how do you train this? And I think I've been to a few different places that train this, and it's one of the, once again, I was talking to Dr. Ahmad Ha, and he's just like, you have to have standard to start with before you go to the field, because it's going to be degraded in the field. So, and that's just the reality of it. So I think US-based nurses that work in our healthcare system, they know what right looks like. They know what the standard is. So when they move into a field setting, they know what's being degraded. You guys, your SOCM medics, you guys have a laundry list of stuff that you have to train. And like I always say, probably the best place to learn just how to do nursing care is just like to get the most bang for your buck is to go into an ICU and just work. And I always like, I don't want you guys to work your weekends, but like the best time to do it is on the weekends when there's not a lot of support around. And those ICU nurses would love to have some folks around just to help turn the patient, clean the patient, like do those things. And that's where you're going to probably get the most bang for your buck and just learn what the standard is to do with one patient over the course of 8 to 12 hours. So that way, when you move into the field, you know what's being degraded. But if you just train on mannequins, it's boring. I guess it's a challenge to train on a mannequin for 4 hours, let alone kind of 12 hours. My advice would be, if this is something that's going to be done, like I would go train it in a hospital and just try to work a couple shifts and get an idea of what that standard of care looks like. So that way, when you get out into the fields, you know what needs to be done. You might not get it all done, but at least you know what you're missing. Versus if we're just doing this on a mannequin and like in some team house, like I really don't think you're going to get a good idea of what the standard of care looks like. So you're going to have no idea what you're missing. So that's kind of my 2 cents of how to train this. So to recap, so when do you start PFC? I think really it's when the life-saving interventions are complete and you stabilize the patient and you're no longer just trying to do life-saving maneuvers. Really, that's when nursing takes over. So that's kind of the answer to that, in my opinion. It's just whatever that means. But so yeah, and then you, like, if you ask ICU nurses, or I think ICU nurses or floor nurses, I think these would be the best patients to think through this problem set. It's like, what do you do first? So you have kind of a laundry list of stuff to get done. Typically, when you land a patient in the ICU, you'll have another nurse helping you, or maybe even two nurses helping you, just kind of prioritize, just doing all those interventions. But if you're a solo provider, solo nurse, in that scenario, it's all linear. You have to start somewhere and go from there. So typically, I would say if you just landed a patient that's had some life-saving interventions and they're stable, you have to make a decision on how often you want to do assessments and how often you want to do vital signs. So that's kind of the priority. Is what you're trying to do is catch changes right off the bat. So typically in an ICU or even in a PACU, like, those vital signs are every 15 minutes. Those assessments are about every 15 minutes, and you're probably going to do those for the first hour. And then in between doing those assessments, you're kind of just, what did the provider order? What needs to get done? What's the fluid rate? What's the meds that are scheduled? Are any of them scheduled? Like, I got to get any of this stuff done now. And then, so like fluids, sedation, is the vent synchronous with the patient? So you're just kind of that first hour settling in with the patient. Just, are they stable? Yes, no. Am I doing everything that I need to accomplish based off of what's the physician ordered in that first hour? And that's kind of that's kind of what that first hour looks like. So now you're past the first hour, the patient is stable. Maybe you could back off on the vital signs. Maybe you're doing it every half hour. If you're infusing vasoactive medications, you're still probably every 5 to 15 minutes, your vital signs. And now what I'm doing is I'm just looking over the entire patient. So I'm looking at all the interventions that were done. I'm looking at the chest tube site. What does that look like? Let me just take a peek at the Foley. How's the Foley site look like? Let me take a quick peek at the IVs. Do they all look good? And I mean, you're doing that when you land the patient, right? So you're also quickly eyeballing the IV sites, making sure they look good. But that's when I really kind of like get a kind of that mental picture of, okay, this IV site looks good, this IV site looks good, etc. And then I'm looking at the dressings. Are they getting saturated? Is the patient bleeding? Is the drains? And kind of going from there. But I would say really that first hour or two that you land a patient, you're just, are they stable? Gather some data, and then start going down the laundry list of things that need to get done. So I would say by the second hour, you have the patient, and whether they're intubated or not, like, pulmonary toileting is a big deal. So if you have a patient that's intubated and sedated, if you think about how you sleep at night, like, you move the whole time. Like, you're moving all over the place. So sedated patients typically don't move. You have to move them. So that's when you're going to, okay, like, remember, we're going to start on the left side. So you turn the patient to the left side. If they're intubated, like the ICU book by Marino states, 30 degrees head of bed elevated prevents ventilatory acquired pneumonia. So can you even elevate the head of a litter? Like, what are they on? So you're going to have to kind of work through that problem set. And then after that, I usually just start from head to toe. I just kind of look at I do my neuro exam up top. I look at the ET tube. Is it still in the same place? I'm looking at doing some oral care, because it probably hasn't had oral care for multiple hours. And who knows when was the last time somebody brushed their teeth if they're out in a gunfight. And oral care is important because you have a lot of bacteria that builds up. That bacteria makes it past the ET tube. You get microaspirate. That's where that ventilatory acquired pneumonia comes from. You can get cysts and different types, not cysts, but abscesses that up in the sella area, which then find their way up in the brain. So oral care is super important. You got to move that ET tube around about every 24 hours. You're just kind of moving it. Eye care, do you have lacquer lube? Do you not? trying to keep their lips from getting cracked, and that's the source of infection. So, and then kind of move down to the anterior portion. You're listening to lung sounds, listening to heart sounds. Is there any change? Listening to bowel sounds, feeling their bowel, feeling their abdomen. Is it distended? Are we thinking about abdominal compartment syndrome? Moving down to the extremities, making sure we didn't miss anything, crepitus in their arms. They still have good circulation and sensation and pulses. Are we missing compartment syndrome? And then kind of going down to the pelvis area. Did we miss any injuries? Is everything clean? The one thing I always people's heads explode when I bring this up. And I'm like, what are you going to do when your patient has a bowel movement and it's dripping off of the bed or the litter or whatever they're on? And now that stool is in their dressing that you just put on from the, finishing up that amputation, the example we gave. Like, what are you going to do with that? Like, how are you going to clean that? So that's real. Like, nurses do this all the time. It's like a big deal. Like, you just did your whole entire bed bath, dressing changes, all of it. And then you turn the patient and you see this, or you walk back in the room and there's literally diarrhea leaking off of the bed. And you're like, I hate my life. So I got to go to nurse anesthesia school. So those are some problem sets that you have to think about. And like, how are you going to solve that issue? Do you even have the class 8 to clean somebody as much as you're going to have to clean them to deal with that, or to do your dressing changes? So once again, I just continue down down to the extremities, and then that's your assessment. So as far as what I would probably do in that prolonged field care environment, and what we did in our, I worked in an ICU at a Role 3 in Baghdad in 2004 to 2005. And that's exactly what we did. We would get these patients, they were out in a gunfight or they were out on patrol, they get hit by an IED, and then they would come to us, all the life-saving maneuvers get done. And then we land them, we make sure that we're not missing anything as far as what the doctor's orders. And then you get to cleaning. And then you just have to, the skin care is probably one of the most important things we did, because what I was trying to explain to medics and to SOCA medics and to other folks is any type of skin breakdown is a source of infection. And these trauma patients, their immune system takes a giant hit. So if you don't turn people and you don't clean them, anything that irritates their skin then becomes a source for pathogens to get in, right? Your skin is kind of your first line of defense against everything. So it's horrible to think about this, and I'm sure it's happened, but you do a really good job of the point of care injury, you do a really good job of the life-saving interventions in the operating room and doing whatever you need to do. And then, just through not turning a patient, you get a large sacral ulcer, and then that's a source of infection. The patient gets septic and they die, right? So they had life-saving injury, they had injuries that were survivable, and now, due to just lack of turning a patient and doing good skin care, 60 days later, they unfortunately succumb to sepsis and they die. The nursing care is a giant portion of this, and it's challenging even in an ICU stateside, let alone trying to do this in a prolonged field care environment. So I was lucky enough to work with some super amazing nurses at a county hospital, which they, you just don't have the funds to have all the gee whiz stuff to clean patients. So one of the things that we used was just Barbasol shaving cream, and it's a lot easier to use than soap and water. Soap, you have to get off the skin, because if you leave soap on there, it dries out the skin. So we used Barbasol shaving cream on our patient population, which typically a lot of them weren't taking baths all the time. And it just really cuts through just about anything. We used it in Baghdad. It cuts through grease. It cuts through blood. It cuts through stool. It cuts through, you name it, it cuts through it. And then also, too, it's good for your skin. So those are one of the things that I always tell people that are thinking about prolonged field care. I was like, just bring a couple 99-cent bottles of Barbasol with you and some washcloths, and you should be able to clean just about anybody and get their skin nice and soft and not dry it out. I'm trying to think if I've answered your question, but like, and then your priorities are going to shift based on what's going on. Like if you're just doing your head to toe assessment, and in the middle of your head to toe assessment, you find the patient has a change. Okay, well, now you're going to have to deal with that change and figure out what's going on.
Yeah. I think maybe before we get into patient change, right? So we mentioned early, so you've done whatever life-saving interventions. You put your chest tube in, you've given blood, whatever. And there's always this like pregnant pause of like, is it, are things working? Like, I think it's working. Like, he's not continuing to crash.
Yeah.
How long are you finding out if he's stable before we start like, okay, like we can continue on doing other things? Because I think it's human nature. I mean, I think it's also not any real difference between winning a gunfight is there's always that pregnant pause. And in combat, that's the time you prepare for, another attack, right? I think in a similar way, you reach that like, oh, we won. There's like this adrenaline dump, and you're just kind of like, whew, all right, like, all right, now I'm going to lunch or, whatever. I'm going to go to the gym. And like, how long do you wait before you're like, okay, this patient is actually stable. Now we can continue doing other things. Because I think in a hospital, it's after surgery, it's like the surgeon's like, I'm done here. He goes to the PACU or the ICU or wherever. Like that's a pretty clean delineation. Like I'm just giving him to you. Now you do stuff. We're all in the same tent. He's on the same litter. We're like, there is no moving him to anywhere really.
Right. You're just like, yeah. So I think that's where you have to have that mental image of you're done with your life-saving interventions, and like let's just say in a US-based hospital, like you're going over to the ICU, let's say with a intubated patient, maybe they just had an emergent laparotomy or whatever it is, and you're hooking them up to your vital signs, to the machines, etc., to the vent. And then I would say for the next probably hour, like you're really you're doing vital signs, you're doing some housekeeping, like you're trying to get just maintenance fluids going. You're trying to, are they on vasopressors? Do they need antibiotics? I got to get my sedation going. Like all of that I would say for the first hour is probably the priority. After that, like if their vital signs are still stable, they're making urine, if you have drains in, they're not putting out like a large copious amounts of blood. And I would say after about an hour, you're like, okay, like let's I can take a breath and go, okay, everything looks good. Their vital signs are trending positively. They're making urine. They're not putting out, like 500 cc's of blood every half hour out of their chest tube. Their JP drains are not filling up. Their dressings that they have on them are not getting saturated. I'm not doing multiple dressing changes. Then I would say, like, whatever life-saving interventions you've done have worked, and the patient's stable. So I would say within probably the first hour, like you could talk to ICU nurses, to include myself. Some patients you land that first hour, like you are just spinning, trying to keep them alive. Like, and you're with the physician in the room, like you're doing fluid boluses, you're still giving blood, you're hanging drips, you're trying to get their sedation settled. They're either hypotensive and not moving or coming off of the bed and hypertensive. Like, these are all the things you're trying to just get the patient into some sort of a stable platform. Some land in a stable platform, and some get to the ICU in a platform that you've got to do a lot of like a lot of medicine changes to get them where you want them to be. So I think it really, the answer is it depends. Like if all you're doing is vital signs and you're doing them every 15 minutes and everything looks good, like the chest tube's not putting out a ton of blood, your dressings aren't getting saturated, you're making some urine, I would say usually about 45 minutes to an hour, because that's what it takes to get a patient. You're turning them during that time, just taking a look at their back. You might not be washing them or anything like that. You're just doing your assessments. And then after that, if everything is still smooth sailing, then I would say it's time to start doing all that nursing care. Okay, let's turn the patient, let's get them cleaned up, let's get all the dirt, debris, blood, stool, whatever is on them off of their skin. And that's when it's starting, right? If you have the ability to do dressing changes, like whatever it is, every 12 hours, every 24 hours, then you're going to get into the lane of your dressing changes. We used a lot of Dakin solution, which I believe was discovered in like World War I, was used in World War II. We used a ton of it when I was in Baghdad. So we were doing wet to dry dressing changes with Dakin solution. And then, I don't I hate to say this, but if your patient is stable in the ICU or on the floor and you're in there just kind of doing dressing changes when it needs to, doing your bed bath, keeping them clean, gathering the data, charting your data, it's boring. And that's good, right? Like if you're bored, or if you're like, all right, like this. So I think a lot of the hard part, I think for SOCM guys and medics in general, is just like, they're so used to the life-saving stuff, and now you move over to the prolonged field care. And as long as the patient's stable, prolonged field care, granted, if you have 30 patients, it's not going to be boring. You're going to be running around with your head chopped off. But if you have two patients, it should be boring. You should just be kind of chilling out. Let me go check his vital. You'll probably be at the litter side, I say the bedside, and just kind of watching the vital signs, charting them when you need to chart them, turn the patient every hour, every 2 hours, monitoring their output. Like, it really should be boring. If it's not boring, that means your patient's not doing well and you're running around with your head chopped off trying to do whatever interventions you need to do to kind of get them stable. So like usually in an ICU for an intubated patient, you're almost doing a good bed bath about twice, maybe, twice in a 24-hour time period. You're turning them every hour to 2 hours, whether it's, you're going from left side to right side to supine. You're doing that oral care a couple times a shift. You're doing Foley care at least once or twice, probably once or twice a shift. And you're doing your assessments all the time, but typically you'll back off on your assessments if the patient's stable. It's kind of from there. I don't know does that kind of answer your question?
No, I think it's good. So another thing, like we're doing interventions like in the field, right? Whether it be IVs, IOs, crikes, what have you. Once we get to some kind of facility or some kind of shelter of some kind, like, okay, like we're being set up here, like, should I be changing out my IVs? Like, should I be doing a good job cleaning the arm, getting a new IV? Look at that crike, like there's literal mud all over his neck. I probably doesn't seem right.
Right. So if I remember correctly, I think the standard is for hospital-based systems in the U.S., any intervention that's done in the field needs to be changed out within 24 hours. Now, to say you're going to do that in a prolonged field care environment where you don't have all the IVs in the world, it's like you don't have all of this stuff. I think it's really, if you were the one that put the IV in, you know how dirty it was when you put the IV in. And that's obviously a source of infection. So I would say it's really based off of how dirty was it when you did it and how does it look now? And that's just kind of a provider or a medic gestalt. Like, you try to change those interventions out. But if you don't have an IV or you don't have like a whole entire cart of IVs sitting on a wall, you're probably going to leave that intervention in and you're just going to keep an eye on it. And then the first sign of it getting red or it just kind of looks angry, like, yeah, you're going to have to change it out. And I always tell people, do not remove the angry, yucky IV until you get a new IV, because usually by the time you're trying to do this, patients have third space fluid, they're swollen, and it becomes challenging to get access in the patient in the prolonged field care environment, especially if you did a large mass transfusion. Keep whatever intervention you have in place, try not to take it out until you have another intervention in place that mimics it. But I would say that's where knowing kind of the US based hospital standards will help you. We will always try to change it out if I have time. Well, I shouldn't say if I have time. I'm going to have time. It's if I actually have enough IVs to do this. Like, for example, in a US based system, you would change the IV tubing and fluid that's in there every 72 hours. If you don't have IV tubing to change to, you're not going to change it. If you have the IV tubing to change, great, go ahead. But that's kind of where you're like, okay, this is standard in the US. I don't have an entire box of IV tubing, so I know I'm not going to meet that standard. So, okay, here it is. It's up there for 7 days or whatever it is. So, but yes,
I mean, like that.
I would say, like, if you have, like, obviously dirt and stuff, you're just going to have to clean that out as best you can. And that's where that shaving cream does amazing stuff. It cuts through everything.
Nice. So that was one of my next questions. So, of course, we're doing everything, sterilely in the field, but in reality, we know it's not. Sometimes we don't actually even put gloves on when we do it because it's combat, right? So it was as clean as I possibly could do it, with my one alcohol swipe down the center there. I don't think it's as clean as I would like it to be, and also don't really have much stuff. Can you rescue that with like just cleaning around the catheter, cleaning around the?
Yeah. So when the ICU where I trained, when I would get even like IVs placed emergently in an emergency room in the US, I would still, when I landed those patients in the ICU, I would still take the tegaderm off or whatever was keeping it in place. I would clean around it as best I could with usually an alcohol-based wipe or whatever we were using at the time, if it was chlorhexidine wipe, and then get it good and dried, and then put a new one over it. So I did that even in a US-based system where, like, and I've worked in an ER, like, you're trying to put these things in as quick as possible. Like, you're worried about sterility. You're going to put alcohol on them. You're going to put it in, but it's still I'm under duress because I'm trying to get this thing as quick as possible. So I might not be paying attention to what I'm touching or things like that. I mean, that's the reality of it. The book answer is it's going to be, you're going to do this and then you're going to dry it and yada, yada, yada. But the book, that's the book answer. But in reality, like, you're just trying to get the thing as fast as possible. And the patient's not clean when you're doing it. So when I was in Baghdad, we would do the same thing. Like, once we kind of landed the patient and everything was good and you knew you were so I would go ahead, I would peel back some of the IV sites and I would clean them up and I would put new stuff on them. And that gives me a good assessment to look at them. So that's what I would do. And I would do that in a prolonged field care environment, especially if you don't have a lot of stuff. But then, like, you're like, do I have another tegaderm? How many of these things do I have? So it's pretty hard to save a tegaderm that you've taken off. It really just depends upon what you have. But I don't think that's a bad idea. And that would be for any intervention.
I mean, I think coverings are a lot easier to improvise than the catheter,
Yeah.
Like, even way back in the day, before we had tegaderms, like, I would just use a 2x2 gauze and tape over the catheter. So, I think those are a lot easier to improvise.
But yes, I would definitely peel back those interventions that were done in the dirt, so to speak, and get them cleaned back up. I would probably not take the IV out unless it just was like horribly soiled. But then again, do you have another IV? Is really the question you're going to ask yourself. And if you don't, you're kind of left with what you got.
Yeah. Another thing you mentioned, you're monitoring, there's a change in the patient's vitals, right? So when did you know I need to talk to the provider? And, this is out of my decision-making ability to make a decision for the patient. How did you know when to call the provider?
So when you're in an ICU type setting and you have one patient, it's kind of a weird thing to say, but you really get to know the patient. And patients do weird things. Like all of a sudden their vitals do weird things. All of a sudden they become hypotensive and you're like, what is going on here? I would say, like, initially you're probably a type of change in vital signs. They get hypotensive, tachycardic, all of a sudden their sats drop. Like, for whatever reason, that's assuming that you've got them on continuous monitoring. That's assuming you've got a pulse ox continuously going. You're probably going to call the provider and be like, hey, this is what just happened. And these are the things that I immediately did to try to rectify the situation, whether that's, I gave them a fluid bolus or gave her a fluid bolus. I turned up the, if you had them on a vasopressor for whatever reason, I increased the amount of the vasopressor I was getting. And everything kind of seemed to smooth out. I think we're good. And that provider, like, it's not in a US based hospital system. They're not driving from home to come in to see them. They're not, like, they're probably going to be sitting in a chair 10 feet from you. I would say, yeah, this is what happened. This is what I did. And they'd be like, okay. And then all of a sudden, a couple hours later, the patient does it again. And you're like, oh, I've seen this before. This is probably fine. So those are things that you just kind of get to know the patient, and then probably over the next couple hours you back off on the vasopressor, like, or whatever intervention you did for respiratory wise. Like maybe you gave them some recruitment breaths with an ambu bag and a PEEP valve, and then everything turned back to normal. It's most likely when you do all those interventions that to do and it doesn't work. That's when you're like, hey, this is everything I just did and it's not working. I need you to come in here and help me. And a lot of the times, like, there's left and right guidelines that are given to ICU nurses and general care floor nurses. Like, if this happens, do this. If this happens, do this. If this happens and you do this and it doesn't work, call me. So you kind of get an idea of a patient. Like, you just have it's like getting to know somebody. It's like sitting down at dinner and just talking to somebody for an hour or two, and you get to know them. It's the same thing with a patient. Even though they're not talking to you and they're intubated, like, you kind of get to know them and the weird stuff that they're going to do and what interventions are going to work and when to call.
Yeah. So initially you start out with some kind of, we call it a wake-up criteria, but, you're given some kind of left and right limits on your patient. And that would be, like, they just run through all the vital signs, or just the ones that they expect to change? Like, I guess, how did they give you instruction?
It's usually just parameters, like keep, blood pressure within this range to this range, titrate this vasopressor based off of these vital signs, right? So kind of give you some left and right guidelines of kind of the top end of a vasopressor, and then once you've kind of reached that top end and they're still hypotensive, and it's like, okay, well, I've reached my limit on the right side, so now I need new limits, or something else is going on here. So, and usually what you see is providers that write these orders, they write them within limits that are fairly tight because they want to be called. If you're going from a small dose of a vasopressor to like a giant dose of a vasopressor, that's a big change. That's something that you want to alert them to and just be like, hey, like, the vasopressor requirements on this patient are going up and up and up and up. I've backed off on the sedation. The urine output is dropping. Something's going on. So that way they can come in and look at all the data that you just gathered and then try to make a clinical call on what they, come up with some differentials on what's going on. So does that kind of answer the question?
No, absolutely.
Yeah,
absolutely.
And it's the same with vital signs. It's the same, like, for a temperature above this, give some Tylenol. Temperature above this, call. Temperature below this, call. Like, SATs below this, call. You're doing blood gases. For a PaCO2 above this, you should probably call.
Mm-hmm.
So, like, you can come up with whatever parameters you want to be notified by whoever's doing that data.
Yeah, because I'm just thinking, it's going to be my teammates. And so I have a bunch of weapons guys and explosive guys and commo guys. They're they don't have any ICU nurse experience. They're
No.
so, and, I guess like in a hospital, the providers are handing off to the nurses so the providers can go see another patient or go to another surgery or do another thing. Hopefully that's not the case with us. Hopefully it's the medic can get some sleep. The medic can get his aid bag ready for the next mission. The medic can go out on the next mission. So it's a little bit different reasoning, but the same type of problem. Somebody's watching them. I'm going to give them a left and right limit as far as this is what you can do while you're here. If it goes outside of that, okay, you need some different help.
Yeah. And I think that's a good way to do it. And maybe with non-medical attendants that are doing medical things, you make those parameters narrower. But that also comes with you sleeping less or being able to do the other 500 other things that you have to get done because they're going to be like, hey, it's outside this parameter. What do you want me to do? Kind of thing.
Yeah. Yeah,
I think
absolutely.
Yeah. So I would.
What
So
other things?
I'm sorry, go ahead. Yep.
I was going to say, so you train with medics a lot.
Mm-hmm.
What other things in all the different, PFC lanes or wherever the nursing care aspect comes into it, what other things do you see us messing up with?
So the part that I have a hard time with and kind of telling, the patients or not patients, but the medics, like the importance of turning somebody. Like when you become a nurse, you learn all the theory behind why you're doing the things you're doing, and it makes it important. And I think you're just telling a medic or a non-medical personnel, like, you got to turn them. And they're just like, why? That's stupid, right? Or like, really? And you're like, yes, and this is why it's important. And you have to kind of give them the backstory to why this is important. And then you can see the light bulbs start flashing. But usually the hard part is getting across that the skincare, the turning the patients, the doing the things we talked about, like cleaning the sites of IV ports, and that stuff is all super important because you're not going to see it as the person on the ground. It's when the patient gets back to, wherever they go, Walter Reed, Tripler, SAMC, or WOMAC, that's when I see, as an ICU nurse or as a nurse anesthetist, like, having a hard time. Now the person's in ARDS because you didn't turn them. And now they've got pneumonia, and now they're dead, right? Yep. Well, that whole process started 5 days ago because the patient wasn't turned.
Yeah. Yeah, or elevated or anything.
Right. So those are the things that we see kind of on the back end, knowing that these things probably weren't done on the front end, and they're really, really hard to treat, super hard. It's a shame because that if these things were done up front, we probably wouldn't be in the kind of the scenario we're in now. And it happens. It's tough. It's a tough pill to swallow to see like a giant sacral ulcer because somebody wasn't turned for probably 12 hours, right? Or 8 hours. And I don't know what the current research is, but I think it's only like an hour or two before ulcers start appearing. And if you think in the trauma patient who's probably not perfused as well as they should be, any pressure point is really going to be hypoperfused. It's almost like a tourniquet on that pressure point. So if you don't turn somebody for 2 or 3 hours, that skin there then becomes necrotic because it's dead, because they weren't turned. So if you've slept on a litter for any amount of time, like, those things are uncomfortable. And like, even like healthy patients with normal vital signs, like, you start to have like big red spots wherever you're laying. So I don't know what the right answer is to that. I know I've spoken to some guys that are probably going to be a little bit more far forward. And I think some like commercial camping mattresses would probably be the best bet. They're small, compact, and you can get them. You can still put it on a litter, but at least it keeps the skin from getting some pressure points. And it's not just the sacral area; it's the elbows, it's the patient's heels, it's the back of the head, it's all of those things, and patients get septic from those, and they
yeah, absolutely. Yeah, I think it's just hard for us to switch gears from, crushing in blood into a patient, putting in chest tubes, doing crikes, tourniquets, etc. Like all that angry, aggressive stuff that's what we like. And then when all those little games are over, it's like, I don't know what to do with my hands. Well, the only thing is like part of that normal kind of repetition is we'll look for more things to do. And, we do lots of vital signs. Maybe somebody remembers put on antibiotics. He's usually the smart guy in the room. And, it's kind of, and I find myself after, ask the students like, okay, well, what's your next plan for the next, hour, 2 hours, whatever. And it's like, well, I guess just vital signs and pain control. And I was like, no, you have more to do. And then I just run through like this giant list of stuff, and they're like, oh crap. And we thought nursing care was like just put the blanket back over him,
Yeah. Well, I mean, I hate to bring this up, but I'll do it. I mean, we have nursing care plans, right? And like I got throttled with those when I was in college, and at the time I was just like, man, these things drive me bananas. But that's really what you're kind of coming up with. It's just like, patient is at high risk for sacral ulcers. Okay. So what are my interventions? Okay, well, I'm going to turn the patient. I'm going to keep them off, keep all their bony prominences as best I can off of whatever is going to cause, the sacral ulcers or the skin breakdown. They're at high risk for a ventilatory associated pneumonia. Okay, so what am I going to do? I'm going to do pulmonary toileting. I'm going to turn them every, whatever it is. I'm going to do oral care. Like, these are the things. And then, and then the number one thing that actually overall decreases morbidity and mortality in hospitals is early ambulation. So let's say you have a guy that does have like a tib-fib fracture. That guy's got to get up and he's got to walk around. I don't know if you have crutches, or just like if I was in a hospital and he was splinted, I'd be like, all right, bud, we got to get up. And we got to go hop down the hallway. Here's your crutch. And that, prevents blood clots, which turn into pulmonary embolisms. Also, that is a giant pulmonary toileting, right? Cough and deep breathe. Like, you're always telling your patients to do that, the ones that are awake. So I think we have this idea of these patients are all going to be intubated and they're all going to be sedated. And I don't think that's what prolonged field care looks like. I think it's going to be people that have a significant enough injury that they cannot return back to the battlefield, that we need to evacuate them back to another level of care, but we're going to be holding on to them for however long. Even a patient that is awake and alert and oriented with like a tib-fib fracture, they can get pneumonia. They can get skin breakdown. Like, all those things can happen to them. They need to be cleaned up. They're going to have to go to the bathroom. Like, all of those things need to take place. So that's where when I was, working on my nursing degree, that all those nursing care plans came up. So, and I want to say the CPG talks about those nursing care plans. And I mean, I don't have to come up with like this, like we had to like giant these things. I wrote them out because I weren't using computers at the time, but I even did them in my first, like my jobs. It's been a while since I've been on a floor, so I don't know if they still do nursing care plans or nursing interventions. I'm assuming they do. But we used to have to write these things out. And we would, at the start of the shift, we would get report from the oncoming nurse, and we would go through the nursing care plan. Like, this patient actually met the goals of this particular thing. They were able to walk down the hall 25 feet and walk back. And that's what they did 3 times today. Sweet. So tomorrow I'm going to try to get them, 30 or 60 feet down the hall 3 times. So those are just some, I'm sure there might be some nurses that listen to this that will want to vomit. Like, nursing care plans are a big deal. And it keeps you honest as the nurse to think like, okay, these are my goals for this patient for today. So the guy with the broken tib fib, like, okay, like, let's say 96 hours, you're not getting this guy out. You can't let him sit on a bed in a litter for 96 hours. Like, you got to get that guy up. You got to get him walking around. Like, you got to do good pulmonary toileting. You got to do good skin care. You got to prevent the sacral ulcers and all those things. You still have to do it on those patients as well. So to tell like your high speed, like doing all the cool stuff, and now it's just like, hey man, you got to get this guy up. You got to walk him, because if you don't, this is the downstream effects, and he's gonna die if you don't do this stuff. Like, yep. He's got a survivable injury that turns into a non-survivable injury because now his lungs are completely whited out, or he's got an infection wherever because we didn't do proper nursing care. So I struggle with that as well. And doing it in a sim environment makes it even more challenging because it's just a mannequin or whatever, it's just sitting in front of you. And you're just like, it's a mannequin, right? Yeah. Yeah. So I think that's where, like, just trying, if you can, once again, it's a time investment to get into a hospital on the weekends and when they're short-staffed. Or I shouldn't say short-staffed, just minimally staffed, so that way you can get the best hands-on experience. And the nurses will love you because it's just another person there to help them, like, move. Like, when you're an ICU nurse, you got to go find another ICU nurse to help you turn your patient. So if they had, a couple of you guys floating around, I'd be like, this is awesome. We'll show you everything.
Yeah. Yeah. Like, that's what I would do for my MPTs, is because in order to get any real procedures, you're going to have to get past the nurses to begin with. Because they'll just block you out and your residents will get it. But if you were smart and you made friends and influenced people like we're all trained to do, you go into that nursing bullpen there, say, I'm so-and-so, this is what I can do. I would really like to spend the next couple of days learning about nursing care. One, you're going to be golden. You're going to learn a lot.
Yeah.
Valuable things, especially when it comes to prolonged care. And then you have this little army that wants to help you, who already knows, like, hey, this patient's getting ready to get a chest tube. I called the doctor to come do it. Would you like to help with that? Or should I go talk to one of these residents who are on their computer or on their phone all day? They'll come to you first.
Yeah.
Because they empathize, and now you've made an effort, which, from what I generally see in a hospital, I don't really see lots of residents putting that kind of effort into nursing the nurse. So you already made your wins that way.
Yeah, so you'd be surprised the residents that do come to help out with those things get treated like gold. But yeah, I agree. Like, if you walked into the start of a shift and you're like, hey, I am here to learn how to do basic nursing care. I want to help you with every bed bath. Every time a patient has a bowel movement, I want you to call me because I need to learn how to clean this stuff up. Every time you need to do a bed change, every time you need to change your linen or whatever it is, call me. I want to do as much of it as possible. Like, you're going to definitely be treated very differently than if you're there just to do procedures. So, and I would even, like, if your non-medical people are going to be doing that, like, grab one of them. Hey man, let's go learn how to do this stuff. Grant, I know you guys have like a laundry list of stuff to do, but if the prolonged field care thing turns out to be like real, like the more people you have, the better knowing how to do this.
Yeah. Yep. Absolutely.
So, but, and I think, and this is, let me just jump on a soapbox here, but
sure.
I really think the P in everybody's PACE plan is prolonged field care, and I really think we need to get away from that. I think we still need to think of evacuation as the P in the PACE plan. And it's, obviously primary would be medevac, alternative would be casevac. You just, if this is simply a math problem. And when you think about what nurses do, and you think about just an ICU nurse, and they might have one patient or two patients if they're stable, they're running around with their heads chopped off, trying to get all the things done that they need to get done. Now let's multiply that by 20 patients or 30 patients, or for whatever number, that's being thrown against the wall. Like, it's like the impossible problem. Like, how do you, by the time you get done gathering all the vital signs and doing all the documentation, you're just going to have to go back to the first patient and gather all the vital signs and do all the documentation. There's no time left to do the things you need to do to prevent all of the sequelae of not doing nursing care. There's like turning patients and pulmonary toiling and cleaning them and doing dressing changes and doing all those things. So I still think the primary plan should be a medevac. And if that's not possible, casevac. And then after that, it's like, okay, we're stuck in a prolonged field care setting, but I think our leaders need to still kind of try to solve that problem of like and listening to a leadership presentation last week by one of the folks over at WOMAC. And so they did this in World War II. Anything that brought soldiers or airmen or Marines, or I don't know if they were airmen in World War II, but anybody to the fight, well, those things still, they transported everybody back to the medical folks, right? So if in the whatever this next large scale combat event looks like, we're still going to be using some sort of a platform to bring soldiers and Marines and everybody else forward. Well, that's a casevac platform. The second all those people unload and they're driving back to wherever they came from. So I really think prolonged field care should be the E in the PACE plan, and evacuation should be the P, because it really just turns into this giant just math time problem. And the more patients you have and the less people you have available to take care of them, the more of these nursing interventions are going to get dropped. Something's got to give, whether it's gathering the data or not doing the interventions. And I would say typically what winds up getting dropped is gathering the data. And now you're just doing the nursing interventions, right? So I'm going to get down off of my box.
No, I think you're absolutely right. Our primary alternate, like our first priority, is trying to get this guy off the battlefield.
Mm-hmm.
Like we know that, ideally having him in front of a surgeon in the ER is the best. What can you do if that's not possible? Well, we haven't really cracked that nut, because we're also never had to, at least in the last 50 years, really crack that nut as far as numbers of casualties that people are thinking of, like it's, GWAT, we got spoiled, evac is 10 minutes out and me on the ground, I'm rushing to finish this march.
Yeah, by the time the helicopter lands.
We got spoiled. I mean, we also, our survival rates went like through the roof, which is outstanding. How do I try to maintain those same numbers, the same survival rate, while simultaneously, taking larger numbers of casualties in a more denied area? That's a harder nut to crack. That's going to take, a technological answer and a tactical adapting to the environment type answer.
Yeah, I there's a really good book I read. It was given to me by one of my surgical buddies was reading it, and I was like, oh, what's that? And anyway, I read the book. It's called Desperate Surgery in the South Pacific, 1941 to 1945. And I would encourage anybody who has anything to do with the next kind of fight coming up to read that book. The Navy and Army cracked a lot of those cracked those nuts a long time ago. I think one of the, I've had this conversation with a few of my colleagues about what we don't do very well in military medicine is go look back at history and go, how did they solve that problem? Because the Navy didn't really have air superiority in the South Pacific, right? They just didn't have it. They didn't have helicopters. So what'd they do? Okay, well, let me go read this book. Oh, wow, that's what they did. Okay, that interesting. Wasn't perfect, but it's a lot better than doing prolonged field care for 7 days. And I also think the risk tolerance is going to have to be higher. Like, I think as GWAT went on, as people's risk tolerance decreased, as it should. But a lot of these Casevacs and a lot of the Navy medical, a couple of the Navy medical ships, they took direct hits,
Mm-hmm.
It's real. So I think that book is pretty good. It talks about each campaign against a couple of different islands, and it's like, it kind of breaks down like, hey, this is what worked and this is what didn't work. We didn't anticipate this. So on the next kind of campaign, we tried to anticipate all the stuff that we didn't think about. And they had some pretty ingenious ways of evacuating guys off of that island. So I would encourage anybody to read that book. It's an eye-opener of what they were able to accomplish in the South Pacific. It's like, some of it's hard to read. You just look at the sheer number of casualties that those guys were dealing with. But they figured it out. They figured it out in World War II. They figured it out in Vietnam. We figured it out in GWAT. So I think we just need to go back and look at history, because I guarantee you it's probably nothing new we're going to come up with. We'll just be like, oh yeah, that's what they did. So, but ultimately, when I read that book, it really was just it's a time problem. You have a guy that has, let's just take for example, an injury to the gut, right? So he probably needs a laparotomy and a washout within 24 hours. So he's what you would say, or she's what you would say, has a 24-hour injury. They need to get to a surgeon in 24 hours or some sort of surgical capability so they can do the laparotomy and they can wash them out. If they get there in 26 hours, it's probably the end result is going to be an expired or a died of wounds patient. So if you have a 4-hour injury and you make it to a surgeon in 8 hours, that's your time problem. When we're caring for patients, I don't think you really know, unless it's a catastrophic head injury or it's some sort of like large surface area burns, that these patients are not going to survive, right? So I think when we're doing our training and we use the expectant category, really think you're going to be taking care of patients that you don't know are expectant.
Yeah.
Right? Like, I think you are going to do all of the amazing interventions, all the great nursing care, but ultimately the time that it takes them to get to the next level of care will dictate whether or not that patient survives, especially if they're requiring some sort of a surgical intervention. So I would hate for somebody to make the decision that, somebody is expectant, and when we're not talking about a giant head injury or a catastrophic head injury or like burns, and then not do the basic nursing care, and then they make it to the surgeon in time, but now the sequelae of the non-nursing care is ultimately what they succumb to. So I think it's going to be a challenging situation. It's been done before. I think that's what we have to recognize and ask ourselves, like, what did they do in World War II when we were landlocked, right? It's like these, you go from Germany to France to wherever else. And then what did they do in the South Pacific? Like when you're looking at like these time problems of the distances to get from one place to another, like how'd they do it? All right, well, maybe we can figure out how to use the lessons that they learned and just kind of adapt it to what the new battle space looks like. So
that sounds crazy. We don't need to learn from them. Should just reinvent the wheel each and every time.
Yeah, well, I always kind of tell the story. It was 2016 when I got my first unit of low titer O whole blood that was cold stored. And I was like, what is this stuff? And then I started like, let me do a quick Google search. And I was just like, use this in World War II? Use this in Korea? They use this in like Vietnam? And I was just like, it's taken 16 years for me to get this stuff? This is bananas. Yeah. So I just don't think we do a very good job of seeing what our brothers and sisters have done in previous conflicts to figure out how we can use what they did and adapt it to the new conflicts that we're going to see.
Yeah, I think you're right.
But anyway,
Kevin, I really appreciate you coming on.
Yeah, thanks for having me. I hope you have a good rest of your day.
Hey, you too.
All right, take it easy.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.